Hello, everyone, and welcome to our Advanced CAP Echo series. We're talking about disruptive behavior and the basics of behavior management today. I know we've all been seeing this, and so I'm looking forward to a good discussion today. Let's go ahead and go on to the next slide. As you're coming in, go ahead and type into the chat your name, which organization you're with, which county you practice in, just as a way of allowing us to get to know all of you. And for those of you who don't know me yet, I'm Joan Jeung. I'm a general pediatrician working with UCSF, and I practice in San Francisco. And then maybe if you could go ahead and launch our Zoom poll. We're doing something a little bit different today than what we've done in the past. We're doing a little bit more of a reflection on just the reality of burnout within our profession. So let's just take a moment to reflect on how we're doing today. Like, what are we carrying? How are we doing? So just take a moment to look at this. And this is anonymous, right? And take a moment to reflect on this and to answer this. And then when also as you're coming in, if you haven't had a chance to type your name into the chat yet, please go ahead and do so. Your name, which county you're in, which organization you work for. So we have a chance to virtually get to know you as we're coming from across the state today. So we give another minute for folks to type names into the chat, introduce yourself, and to answer our question. Because sometimes it's good just to stop and think how we're doing and to reflect on that. Just give a couple more seconds for people to type in our intros. Question. Okay. Great. So I think we're going ahead and sharing the results here. Does everybody see that? So it seems like we're carrying some stress, right? Like no one's free from it here. And sometimes some of it's a little persistent. I think it reflects very much of what the load that we are all carrying. So I'd like to turn things over to Lauren Haack to lead us in a grounding exercise.
All right. Hello, everyone. Happy Valentine's Day. So this is one of my favorite grounding exercises. I like to do it with patients and families and teachers. And it's actually a series of guided meditations that the Monterey Bay Aquarium put out during COVID. And so this one is with moon jellies. We're not going to do the whole 10-minute meditation. We'll just do about a minute of it to get you a taste, and then we'll jump back to didactic. So feel free if you want to turn your cameras off, get in a comfortable position, and just go along with a guided meditation.
Hello, everyone. It's so good to see you here again with us online at the Monterey Bay Aquarium. My name is Emily, and for the next few minutes, I'm going to help guide you through some mindful meditation with our moon jellies. Today, we're going to focus on releasing tension in our bodies and letting the peaceful flow of the jellies inspire our meditation. So, let's relax and settle in. First, find a place to practice comfortably. Once you're in a comfortable position, begin by relaxing your eyes and letting them fall into a sort of soft focus on the image of the moon jellies before you. Notice your breath without trying to change it. And notice also if you feel tense or relaxed without trying to change that either. Inhale through your nose, and then exhale through your mouth or nose. Continue to take deep, full breaths in through your nose and out through your mouth. As you breathe, become aware of the state of your body and the quality of your mind. Where is your body holding tension? Do you feel closed off or shut down emotionally?
Okay, so hopefully that was a nice little start for everyone. If you're interested in those, you can feel free. Oops, sorry, that is the wrong text I pasted in. You can feel free to just Google or go on YouTube and search Monterey Bay Aquarium meditations. They also have live streams of their cameras in real time. So these are real fun if you have like a patient in your office who you feel like you need to do some grounding with, or you feel like you need some grounding in between your clients. These are one of my favorite tools.
We'll go to the next slide. So I'm Lauren Schumacher, one of the CAP psychiatrists. I tend to answer the phone on Mondays. And so we're excited to have you guys here for the second Project Echo Advanced for pediatric primary care providers. We'll be recording the didactic portion for posting later, but not the case discussion. Reminder to please keep your cameras on. The idea is for this to be a sort of virtual brown bag lunch and really trying to give you guys a sense of community. And it really helps when people have cameras on. We know this is during lunch and encourage you to eat. And I think we're all used to people eating on cameras at this point. And you know, the idea with the case discussion piece is really to get a chance to discuss a tricky case or and think through kind of what are some of the challenges and issues that are going on with the case, as well as then thinking about kind of next steps and issues. But this is really, you know, the idea is to kind of all work together to help people where they're at with that case. And it's certainly no need to have it be a kind of model case where you already, you know all the details and have everything figured out, because that's not life. And a reminder, case presenters get American Board of Pediatrics MOC Part 2 credit for sharing a case. You're also encouraged to continue to call CAP and call us to discuss cases. That's what we're here for. And you're also welcome to request a rock psychologist for more individualized coaching, including with our speaker, Lauren Haack. And so today's didactic is about disruptive behavior disorders. I'm going to take a moment to introduce our speakers for today. First, we have Lauren Haack, PhD, who is a UCSF Associate Clinical Professor and attending psychologist in the Department of Psychiatry, specializing in cultural influences on mental health conceptualization, assessment, and treatment, and accessible, culturally appropriate, and technologically enhanced evidence-based services for vulnerable youth and families worldwide. She provides behavioral and cognitive therapy and clinical supervision in the UCSF Mood Anxiety Clinic and the Hyperactivity Attention and Learning Problems Clinic. Dr. Haack also provides instruction and supervision in the UCSF Multicultural Psychology Training Program, the Child and Adolescent Psychiatry Fellowship, and the Juvenile Justice Behavioral Health Team. She's a member of the UCSF Department of Psychiatry Diversity Committee. Dr. Joan Jeung is a general pediatrician and clinical professor of pediatrics in the Division of Developmental Medicine at UCSF. Prior to coming to UCSF, she provided pediatric primary care in a federally qualified health center in Oakland, serving mostly Asian immigrants and refugees for 10 years. She serves as a senior associate director of CAP, where she helps to oversee CME activities, like our CAP Echoes. Her research interests center around integrated behavioral healthcare models in pediatric primary care and trauma-informed care. We're both very excited to have you guys here today to talk about disruptive behaviors.
Thank you so much. Neither of us as speakers have any personal financial disclosures to share, and here's a little information on the federal and state funding sources that help to support CAP in this educational activity. Next slide, please. These are objectives for today, and I know many of us are seeing disruptive behaviors in our primary care practices. We want to be able to recognize these issues when they come up, including when there might be a diagnosable disruptive behavior disorder. We want to be able to give some start on guidance for parents on like things they could do at home, resources they might be able to access in the community, including psychosocial treatments for disruptive behavior disorders. And we want to identify when medications might be useful, even though they're not the first line treatment by any means. Next slide, please. Okay, so what do we mean by disruptive behavior? And there's a huge spectrum. On one end, there is completely age-appropriate and developmentally normal disruptive behavior, like during your toddler years or some of the teen years, and the normal ups and downs that come along with it. And then on the far end here, you have clearly developmentally abnormal or severe disruptive behaviors that are maladaptive, even like violating. And some of the words, and I'm not fans of any of these particularly because they seem kind of judging, but you will often hear the terms oppositional, defiant, non-compliant, aggressive, violent, impulsive. This is the kind of general category of behavior that we're talking about. So then how then do you distinguish the normal from the abnormal here? A lot has to do with what's developmentally appropriate at this age, how frequent and how severe is this behavior, how pervasive is it, and then consider the use of rating scales to help you to figure this out. Next slide, please. So there is this big category of disruptive behavior, and then there are actual diagnosable disorders. What we see on this slide are the most frequently kind of diagnosed ones, including oppositional defiant disorder, which lasts for at least 6 months, just persistent pattern of angry, irritable, defiant, argumentative types of behavior. And then as you move up in the severity scale, generally as the kids get older, if the badness continues, conduct disorder, where you actually get violation of the rights of others, or a violation of societal norms, and this lasting for at least a year. There are other diagnoses like intermittent explosive disorder, where you have these major aggressive or violent explosions, characterized by a certain amount of aggression, physical or verbal, happening at least 3 times in 12 months, but there's a recurrence. And there's disruptive mood dysregulation disorder, where you have this kind of chronic irritability punctuated by temper outbursts and explosive episodes. And then there's other and unspecified, when there's a lot of this kind of behavior, but doesn't quite fit into any of these buckets. Something that's really important to consider is that these are still largely symptom checklists, doesn't necessarily say why these behaviors are happening. And there are lots of frequent comorbidities, things like ADHD being a frequent one. Mood disorders can factor into behaviors like this and can be an underlying etiology, along with anxiety. Finally, we need to remember that PTSD and trauma can show up with lots of dysregulated behavior that can be described in these ways. And so there's a real danger of misdiagnosis. And whatever ultimate label we choose to use, it's really helpful to think about the multiple possible driving factors that are underlying the behavior. Next slide, please. So when we're hearing about disruptive behavior in primary care and parents are bringing these concerns to us, what do we do? I'd say the first thing is a quick safety check. Is there neglect or abuse going on? Is there substance abuse for an older kid, for example, or even is there a potential danger to others in some of the behaviors that are being described? Some screening tools that may be useful depending on the developmental stage and the age of a child. For younger kids, I like the SWIC. I don't know how many of you guys have heard of it, but for kids 0 to 5, it'll combine developmental screening along with a behavioral symptom checklist, along with family risk factors and social determinants of health. So that's a great one for the younger kids. For school age and older, we have the pediatric symptom checklist, which asks about externalizing behaviors, which basically overlaps with a lot of the disruptive behaviors we're talking about, along with the Vanderbilt's, which in addition to asking ADHD symptoms, also ask about ODD and cognitive disorder questions and the DBD scale. Finally, in younger kids, you really want to consider, I want to say, there are special considerations here because so much is still evolving. It can really range from a challenging temperament and maybe some difficulties in the fit between child temperament and the adult temperament also have to factor in whether or not there's developmental delay or an emerging neurodevelopmental disorder. So add that to the differential along with the possibilities of a trauma history. So think about screening and say, think about how you're going to screen your kids. Think about the safety. Next slide, please. And so another thing, as we're hearing about this in primary care, is that it's really hard to talk about these issues. And for parents, they're kind of in a vulnerable place too, in bringing this up out of fear of maybe being judged. It's like, because, this is all pretty delicate, and the kids may end up feeling judged and blamed as well. And there can be feelings of stigma. So validation is a super important tool, both with the youth and also with the parents. So it makes sense that this has been difficult. Some other things is that with this kind of, with a set of concerns, parent level intervention just works a lot better than child level intervention, or at least we have more evidence that this works. And even though parents are coming up with a lot of frustrations, often saying, but I've tried that and I've done that and I've heard, many times we might be hearing these things, or just the frustration that can come with the amount of work that it'll take to actually address this. It's good to be reminded that you're going to pay up front or you're going to pay later, right? You're going to put in the work now or you're going to put in the work later. And the upfront prevention can often prevent, the upfront work can often prevent worse downstream outcomes and even more work down the line. So next slide, please. Okay, with that, I'll turn this over to Lauren Haack.
All right. So when we're working with families of youth who have disruptive behavior, one of our greatest tools is something called a functional behavior analysis, or a simpler term is a before and after model. Because disruptive behavior, just like any behavior, is happening for a reason, right? It's likely being reinforced, even if that's accidental or inadvertent reinforcement. It's serving some sort of function for that child. And so if we can figure that out, if we can figure out what function is this behavior serving, why does it keep happening, what is leading up to that behavior in the environment, or what we call that antecedent, and then how is the behavior being reinforced? What are those consequences after the behavior happens that are all making this more likely to keep happening and this cycle to keep continuing? That's going to give us clues for how to tweak the environment and our responses to the child's behavior to encourage new, more effective behaviors, right? So the first step is the B. We want to, really narrow in on what is the actual behavior that we're seeing. And we want to be really non-judgmental and objective when we're describing that behavior. So I often talk to families about, imagine you were writing a screenplay. How would you write out the actor to show this what your child's doing so that anybody would understand it, right? So I might not understand what being lazy is. I might think that looks really different than you do. But this behavior here, child screams and throws a fit we could even make that a little bit more objective, right? Child screams and kicks their feet, refuses to get in the cart in the store. Anybody's going to understand that, right? And then we want to look at, well, what is the setting? What's the setup for that behavior? Oftentimes we're going to a store and my child wants something, they ask for something at the checkout or a new toy, and I say no. And that's what precedes this screaming and kicking. And then what happens after? What's the response, right? And when we hear the word consequence, that oftentimes triggers in our mind something negative, but really we're just talking about whatever immediately happens after. Well, we're in public, I'm really embarrassed. And so a lot of times I just give in and I give them the toy. Well, clearly this behavior is serving a function for that child, right? They're getting the thing that they want. They're getting, the toy, maybe they're getting mom's attention or other people's attention in the store. Maybe it's communicating something that the child is really unhappy or needs more support, right? And clearly this is going to keep happening again, right? Because we've reinforced that child to kind of act in this way to get what they want in the store. And the parents reinforced to just give in. They've learned that that's the way to get out of the door, right? And so if we go to the next slide, once we've sort of helped the family think through that ABC of what's going on now, then it gives us a sense of how can we increase behaviors that we want to see and decrease those behaviors we don't want to see. And so really we have most control over what happens right before and what happens after. We don't have a remote to just like change the way our child's behaving in the moment, right? So some things that we know work really well. It's easier to increase desired behavior than to decrease behavior we don't want to see. So we give attention for that behavior we do want to see, right? Immediate, really specific labeled praise, right? Thank you so much for getting back in the cart after I said no in the toy aisle, right? Really specific. Wow, I see that you're continuing to sit quietly in the cart. Thank you so much, right? Continue paying attention to when they're doing the behaviors we want to see. And then also, can we add something tangible on, right? So maybe we have an agreement set up that, hey, listen, we got to go to the store. We have to go to Target and we're just going to get groceries. And once we make it through the grocery trip and you're staying in your seat and you're following directions, we can go to the park right after I put the groceries away, right? The more immediate and consistent that reward can be, the better. And it doesn't have to be big or expensive. A lot of times it can be a preferred activity or a choice. You know what? When we get out of the store, you can choose the radio station and the car ride home. That's one of my daughter's personal favorites, to my dismay, I have to say. Then if we still are seeing behaviors that just won't curb with the positive strategies, we can look at some of these other really effective negative consequences like planned ignoring, right? So I'm just going to ignore as my child keeps asking for the toy in Target, and I'm going to keep giving their focused attention when they calm down. Maybe we do things like timeout or losing privileges, right? So the only way you get to earn screen time when we get home is if you follow the directions in the store. And I really like this analogy that behavior plus attention is going to equal that more behavior, right? And so if we can catch them being good, if we can really lay on the attention for those even brief moments of progress, of steps in the right direction, we can start seeing that build up more and more. And so family-based treatments like parent management training really build upon these foundational models that we just talked through, right? They also work on the knowledge we have that families of youth with disruptive behaviors experience more stress, more conflict, more chaos, and those parents feel less efficacious. They don't feel like they have the confidence to know how to effectively parent their children. And so our goals we like to call the 3 C's, right? We're really going to coach the family into being more consistent with clear expectations and really frequent celebration of steps in the right direction. So usually these treatments start with providing psychoeducation about disruptive behavior disorder. Why are they happening? Try to take that shame and blame away. We're going to start with improving those negative interaction cycles that have built up inevitably over time. We're going to talk to the parents about setting really clear and reasonable expectations with predictable positive consequences. And then also teach together, especially as the children get older and their development is more advanced, involve them in strategies like problem solving and effective communication. So if we go to the next slide, you can see that there's a lot of sort of brands or flavors of these treatments that all have pretty good effectiveness and efficacy findings. So really, if you can find any of these, that's great. And they work for children with attention conditions like ADHD, as well as disruptive behaviors. And so again, let's just take a look at a parent-child interaction cycle that is talked through at the very beginning of these type of treatments. So if we could advance the slide, we kind of talk to the parents about, well, what's a really common direction that you give your child, like put your backpack away. And if we advance, let's say the child doesn't comply. Okay, so audience participation. What might a parent do in this situation before they've had all this fancy parent training? Like, what's a natural parent response? They got to get out the door. They're already late.
Just do it for them.
Okay, we could just do it for them, right? Maybe the parent does it. Maybe the parent tries to give the instruction again, but they're probably not going to do it in the same way. If we advance the slide, maybe they're yelling at this point, right? Like, come on, just put your backpack away. Now, let's say this works. Let's say the child then does it, right? Well, now the child's learned, wow, I don't really have to do anything until my parent yells. And the parents learned, well, I got to go straight to yelling, right? Using a calm instruction doesn't work. But let's say if we advance, the child still doesn't comply after I've yelled. What might I do? Just like you all said. So if we hit advance twice on this slide, maybe the parent makes a threat, right? If you don't put your backpack away, we're not having screen time all week. Or maybe they just do it. They say, fine, I'm just going to put the backpack away for you. Like, we got to get going, right? Well, now what has the child learned? If I just like wait it out, my mom's going to do this for me. And the mom's learned I really can't expect these things from my child. I'm just going to have to do them for them. And so these are the cycles that the families in your offices have gotten themselves into. And these are the cycles that these treatments are really focused on turning on their head. So if we go to the next slide, here are all of the different strategies that are covered in these treatments that are mapped onto those 3 goals of consistency, clarity, and celebration. And let me just nip this in the bud, this thought that's probably in all of your minds, but what if we can't find those treatments for our families? The good news is these strategies actually are not rocket science, right? They're usually things that we all know in theory work. We just need some support in figuring out how to implement them consistently in our households under stress, right? And so we have a lot of resources at CAP that can help you coach families in these strategies. For instance, you could do a rock call, as we talked about, and we could talk through some of these strategies. And also some of our Echo and webinar series have featured these strategies, and we have handouts or online resources for them. So just to give you a little bit of a preview, if we advance to the next slide, these are some of my personal favorite online resources that cover these strategies. Up here at the top left, there's a video library. A lot of these videos are also available in Spanish, and they talk through some of these main strategies. I'll say they were filmed during COVID, so they have a little bit of that lens, but really those strategies are helpful anytime. And then over here on the top right, we've got the Collaborative Life Skills Program website, and that has handouts and tips for some of these different strategies, as well as templates for home behavior plans and reward ideas. On the bottom left, there is a video and handout library from CHAD, which is a really great organization for folks with attention disorders, which again have a lot of overlap with disruptive behavior disorders. And then on the bottom right are some videos that they're all available in English, Spanish, and Vietnamese that cover some of these strategies. So if you have even a couple minutes in your visit with your families, you could pull one of these videos up together and watch it. And then lastly, I'm going to turn it over to Joanne to talk about how does she talk through one of these strategies in her office visits.
So I'm a big fan of special time, which is on the next slide, or time in. It's a great brief intervention in primary care. So it's basically scheduling 10 minutes a day, and it doesn't have to be very long, but the idea is that it's scheduled and it's sacred. If you have a good day, you have special time. If you have a bad day, you still have that special time. And what this allows for the child to understand that they're going to have undivided parent attention at this in a predictable way, so they know that it's coming. And the beauty of this is undivided parental attention. You're not doing this with chores. You're not going out and running errands. You don't have your phone with you. It's one-on-one, undivided parent attention with no interruptions. And that's just gold. The whole idea is to have fun together. So the child picks and leads the activity. And this is not about correcting the kid or telling them how to do it better. This is really just having fun together and enjoying each other's company. This is a way to turn that the negative parent-child interactions kind of on their head. And when the kid and the parent can enjoy each other again, this is like money in the bank. Every time we have to scold a kid or correct them, that's money out. This is money in. And it helps to reestablish a kid's motivation to try, because behavior change is hard, and this helps to reestablish that motivation to try. Think about the boss you like versus the boss you don't like. And this kind of helps the parent to be an authority figure that's a little bit better liked. So this is a positive, brief intervention that we can offer. I go to this all the time. Next slide, please. As we said, this kind of parent training and behavior management is available in the community. One of my favorites is Incredible Years, and that's the pyramid that you see here. And what I love about it is that you see at the base are all these parenting strategies that you want to do the most of. And as you go up the pyramid, there are more and more parenting strategies, but you want to do a little less. And as you go further up, a little less. And finally, way up at the top, the most selectively applied ones should be consequences. Typically, you'll often see this reverse, but I like going through this pyramid with families. Again, it's not rocket science, but what you have in the color part of the pyramid are the strategies, and what you have to the side are the benefits. And you can see all that play and talking and listening and special time helps to build attachment and cooperation, which is often in short supply by the time families come to us. So I love the Incredible Years. Just doing a little plug for it. And I'm not paid by them either. Next slide. One thing that we have to warn our families is that at the minute you start setting limits, you will often see an uptick in that challenging behavior as the child is testing to see, is that limit really there? And so parents have to be warned about this ahead of time, that the extinction burst, a lot like with sleep training, will likely come. But if the parent is calm and firm in maintaining that limit, sooner or later extinction will occur. Think about the elevator button. Okay, kids have learned you push this button and a parent will react in a way that gives me something I want, right? Now, if the parent is trying to stop that, they're going to keep pushing that button, right? See, hey, it worked before, until they're finally satisfied that button doesn't work anymore. So this warning has to be given to parents that this is likely to come. It will get a little worse before it gets better, but it will be worth it. And the next slide. So all this is parent-focused treatment. We're training parents on how to basically work with behavior and giving them some behavior management tools. And this kind of psychosocial treatment is first line. Okay, medication is not first line. This kind of psychosocial treatment is first line, right? Now that's mostly parent-focused, but there is child-focused as well. And that's like problem-solving therapy, cognitive behavioral therapy, teaching the kids some coping skills. Occasionally, we will turn to medications as a second-line treatment. If there is ADHD, there's pretty decent evidence to suggest that stimulants will help. As you're addressing the impulsivity, some of the disruptive behaviors that result from the impulsivity should go down. Sometimes it's worth a trial of alpha agonists if there's an impulsive element to the disruptive behavior, even apart from an ADHD diagnosis. But for me, as a general pediatrician, that's usually where I draw my line. If I think there's something more needed after that, I usually bring up our psychiatry colleagues and say, hey, would you consider something else? And what may be considered in these cases would be atypical antipsychotics or mood stabilizers. But that's not in my personal toolkit.